Hi, everybody.
Hi, Michelle. How are you doing?
Hi, Nicole. Good. How are you?
Good. Welcome to SDSF Live. Please let us know where you're logging on from. I'm Nicole Shin from Texas, and this is Michelle Grinnell from Michigan. SDSF Live is brought to you by the Schwakman Diamond Syndrome Foundation, providing support to families around the world. We are currently live from Facebook and YouTube. You may comment from both platforms, and we'll feed into our feed. This show is public. Please don't ask any personal questions that you want anyone else to know. These shows do serve as a library for patients and families, and any resource anyone needs on YouTube for later.
Hi, Nicole said it, but I'm Michelle, and I'm from the little tiny backwoods of Michigan, and we are super excited to have you guys back ready for Christmas. I hope everyone's getting in the holiday season and
I'm
feeling
wearing
all
sequins for our holiday show.
I'm not. I wish I would have gotten the memo that it was a holiday show because I have an entire closet of ugly Christmas sweaters. Some were hand bedazzled by me.
We should have done that.
And bedazzled. Maybe we can sneak in another show before Christmas. Crazy. I love that I can see we've got people logging on from Texas and Pennsylvania, and Jackie's here from New York, and then someone from Denmark. That's my favorite part of this show.
I
is that
know.
we have so many people. Nicole didn't mention it, but as it's uploaded to YouTube later, that will be available to come in different languages with subtitles and captions. But we also do the best we can while we're live. And now from Australia, look at it. We're like global. Does that mean we made it? I think it means we made it. Our guest tonight this evening is Dr. Chris Reilly. Dr. Reilly is an adult hematologist, oncologist at the Dana-Farber Cancer Institute with expertise in inherited blood disorders and leukemia predisposition. Through collaboration with Boston Children's Hospital, Dr. Reilly is developing a clinical infrastructure to facilitate a seamless transition from pediatric to adult care for SDS patients. The care of SDS patients is complex, and Dr. Reilly works closely with other subspecialty physicians to provide comprehensive care for patients and resources for families. In the lab, he is focused on understanding how inherited gene variants influence the development of bone marrow failure and risk of leukemia. That was a lot of words, so if anyone needs me to repeat it, I've got it nailed down now. And impressively, Dr. Reilly is live with us out of Atlanta, Georgia, where the American Society of Hematology conference is happening this weekend. So
thank you, Dr. Reilly.
Thank you for that introduction. Happy to be here.
Yeah.
We're happy to have you. I know it's a very underserved part of our community that we need a lot of hematology. I know at ASH we have a sign right now that says we need adult hematologists.
Right.
There's not enough of you. So thank you for what you do. And with that, we will turn the floor over to you for your presentation.
Excellent. Thank you so much. All right. So let me try to share my screen. And thank you again for organizing this. This is an amazing mechanism to reach a lot of patients and families in this way. So I think it's amazing. So let me just do this. And let's see here. Slideshow. Can you see my slides okay? All right. So as mentioned, so I am Dr. Christopher Reilly. So I am currently at Dana-Farber, and my primary clinical and research interest is caring for patients with Schwakman-Diamond syndrome, as well as other inherited bone marrow failure syndromes. And so what I'll talk about today, and here's just a general outline, is I'll first give a few introductory remarks about my training and background, and then share some general information about Schwakman-Diamond syndrome as a disease entity, and then go into some more general challenges that patients with SDS face, both for patients and families, and then have some additional remarks regarding aspects of transitioning from pediatric to adult care, which are quite unique in this disease, and then also speak about the clinical management of adult patients with SDS with an emphasis on the bone marrow and blood complications of the disease. So just by way of introduction, so I grew up just outside of Orlando in Florida. That's where I attended undergraduate and medical school at the University of Central Florida. And since then, I've been in the Northeast. So I did my internal medicine residency at Penn in Philadelphia. And then for the last really almost 5 years now, time flies, I've been in Boston at Dana-Farber. So I recently completed my fellowship in hematology oncology and was fortunate enough to join the faculty in the leukemia group. And my clinical and research practice is fairly unique and specialized. And so I really spend the bulk of my time in clinic treating patients with both Schwakman-Diamond syndrome as well as other bone marrow failure conditions, and also treat patients with active myelodysplastic syndrome and other blood cancers, including leukemia. And so many of you on this group will also know Dr. Akiko Shimomura at Boston Children's Hospital. And I work closely with Dr. Shimomura to establish an ongoing program for pediatric transition to adult care for patients with bone marrow failure. And in the lab, I believe many of you may also know Dr. Coleman Lindsley, who's a leading researcher in the field of leukemia and particularly bone marrow failure predisposition. And so I've been in Dr. Lindsley's lab now for going on 4 years. And my primary objective there is to understand the genetics and biology of disorders that predispose patients to getting leukemia. So just by way of background, I know many of you are very, very well versed in what Schwakman-Diamond syndrome is, and I've read many, many of the same articles, but I wanted to just spend a few moments just giving some background for anyone that's less familiar. And so Schwakman-Diamond syndrome is a rare, and when I say rare, it's about 1 in 76,000 individuals. So it's certainly not a very common condition. It's quite rare. And it's an autosomal recessive condition that affects multiple parts of the body, so all cells. And I wanted to take a second and explain what I mean by autosomal recessive, because those words may not be familiar to everyone on the call. And so we all have DNA that's inherited both from our mom and our dad, and every gene in our DNA has 2 copies, one from mom and one from dad. And so in an autosomal recessive condition, what that is referring to is the fact that, and hopefully you can see my mouse, is that if you have a gene that either works well, denoted by this check mark, or a gene that doesn't work as it should, this X, if you have a parent that has one copy that works and one does not, and another parent in the same situation, children from that couple, 25% of them will have 2 copies that don't work as it should. And that's exactly what we're referring to when we say autosomal recessive. I think it's important actually to highlight this for the reason being is that sometimes, and both in the context of evaluating patients for Schwakman-Diamond syndrome, but also other conditions, is the concept of a carrier state. So what I mean by that are individuals that have a single copy of a gene that doesn't work as it should. And so as it is very important to understand and diagnose patients with Schwakman-Diamond syndrome and understand how to treat them, I think it's also really important to recognize carrier states from the disease itself, because we certainly don't want to be prescribing any treatment for patients that don't need it. So that I'll just lead with that comment about the inheritance pattern. Now, we do know a lot more now than we did 20 years ago about the genetics, about the underlying cause of Schwakman-Diamond syndrome. And the overwhelming majority, about 90% of cases, can be genetically characterized by recurrent mutations or changes to the DNA that are inherited from either mom or dad, and in this case, both, and the gene known as SBDS. And so I'll talk a little bit more about that in some of the subsequent slides. There are a handful of other genes that have also been characterized in patients with Schwakman-Diamond syndrome, and just for completeness, I've listed them here as well. And there are also patients for which we still have not really found the clear genetic culprit in the cause of their condition, and that's something that we're actively working on the research side of things. Now, the manifestations of Schwakman-Diamond syndrome, there are many variable phenotypes or conditions that can arise in patients, but the hallmarks really are pancreatic function deficiency. And so the enzymes that we all make in our pancreas that allow us to digest fats and sugars and various proteins in our diet are not made in sufficient quantity in patients with Schwakman-Diamond syndrome. And so they can run into issues where they are unable to digest their food properly and they have malabsorption. And certainly young children, when they are first diagnosed, may have what's known as steatorrhea, or really greasy stools, and they may also have difficulty gaining weight early in life. One of the other hallmarks of the condition is impaired blood production, and that's something I'll talk about as the talk proceeds. But it's a primary inability to make healthy bone marrow, healthy blood cells. And this can be impacted in many different ways in terms of making the cells that fight infections. And we'll talk a little bit more about that. Those are called neutrophils, making red blood cells. And so patients can become anemic where they have too few red blood cells, or low platelets. And platelets are the type of cells that help the blood to clot and to prevent bleeding. And so the impairment of blood production is a hallmark of Schwakman-Diamond syndrome. Relatedly, patients with Schwakman-Diamond syndrome are unfortunately at increased risk of developing blood cancers in the bone marrow. And so there's a predisposition to developing leukemia that requires close clinical monitoring. And that's something that I'm particularly interested in. And I'll speak to that in subsequent slides. And this is a very nice table, a very detailed table that was from a publication just a few years ago about Schwakman-Diamond syndrome. And I show this for a couple of reasons. One, again, is simply to highlight the cardinal features of the condition. So that being impaired blood production, this leukemia risk that's inherent to the disease, as well as the pancreatic and GI manifestations, but also to highlight that patients can have many, many other signs and symptoms related to Schwakman-Diamond syndrome. And I've listed just a few of them here in this table. But these also include cardiac abnormalities, so heart conditions, skeletal abnormalities as well that can impair, the quality of life for patients at times. There are neurocognitive and behavioral issues that do arise in patients with Schwakman-Diamond syndrome that themselves require dedicated care and attention. And I highlight this also to make the point that while we can look at a chart like this and try to understand all of the components that might be seen in a patient with Schwakman-Diamond syndrome, the key take-home that I would tell both providers as well as patients is that the manifestations and individual patients can be very variable. And this has been studied quite extensively in the Schwartmann-Diamond syndrome registry, looking at how patients present and how do they continue to do clinically over many years of follow-up. And so what we can say with confidence now is that patients can have very subtle findings. They may have no findings in certain of these categories, or they may have very severe manifestations. And so it's highly variable. And I think it's an important concept to keep in mind when thinking about the disease. And so I mentioned the Schwartmann-Diamond syndrome registry, which is an unbelievable resource. And so if you haven't had the opportunity yet, this is the website. I highly encourage everyone to visit it and see the resources that are available. But this is exactly what is needed to study a rare disease like Schwartmann-Diamond syndrome, and in a condition where we really want to learn as much as we can from each patient's experience. And so this is a partnership that has been laid out most notably by the director, Dr. Akiko Shimomura, who I mentioned earlier, as well as the co-director, Dr. Myers, who have really organized this registry. And so this is really a partnership with patients that is set to achieve the goal of accelerating the pace of scientific discovery about the disease, about what causes it and how it can be best managed. And at its core is a central repository of patient medical records, SDS patient files, bone marrow samples, and banked blood tissue as well for additional research. And this is, I think, really an important point to highlight, is that this is an opportunity of empowering both patients and family members to be really active participants in the research. And so I think it's something, and I think this segment that we're on now is like a testament to that, that really we want to empower patients and families to continue to learn and continuing to improve the care of patients. And so a few words just about what we're doing in Boston at Dana-Farber. And so working with Dr. Shimomura has been fantastic. And so the goal here is to really build a cohesive infrastructure and a seamless transition for patients as they are approaching adult care. And so this idea of having a dedicated pediatric and adult center with expertise and knowledge for patients that have Schwakman-Diamond syndrome. And so this is a project that has been many years in the making, but really starting to come to fruition quite recently. And so my clinical efforts are geared towards this. And so I have been seeing patients in a couple of different capacities. And so as patients are diagnosed typically very early in life with Schwakman-Diamond syndrome, they then need at some point to transition to adult care. And I'll mention in a few subsequent slides some of the challenges that comes with that. But for the longest time, there have not been many places, dedicated places for patients to receive, to continue to receive ongoing, highly specialized care related to their Schwakman-Diamond syndrome. And so now we're receiving referrals of patients that were diagnosed and treated at Boston Children's Hospital by Dr. Shimamura and colleagues who are now ready to transition and are coming to see us at Dana-Farber. And relatedly, with our work with the Schwartmann-Diamond syndrome registry, we're also hearing from patients and providers across the country and around the world, in fact, who have additional questions and are seeking answers for what is the best approach for their patients. And then I also have to mention, going back to what I said a few moments ago about the highly variable presentations that patients can have with this condition, is that we're also diagnosing adults with this. And so the idea that patients are uniformly diagnosed very early in life is not always the case. And so we have certainly had patients diagnosed well into adulthood with bona fide Schwakman-Diamond syndrome, with all the attendant risks associated with that. And so I'm happy to speak to that as well. And so just to touch on kind of what we do for patients, and so we really strive to do a comprehensive clinical evaluation for all patients that are referred to us. And so this includes a complete history and physical exam, as well as, importantly, I should have bolded this, is a review, a formal review of all bone marrow biopsies. And I think this is really important because as Schwakman-Diamond syndrome is a rare condition, some of the features in the bone marrow can also be rather unique. And so it's helpful to have the expertise of pathologists who have seen many cases of Schwakman-Diamond syndrome to add context to the evaluation. So that's something that we strive for in all of our patients. Another thing that we're doing routinely for not only all of our Schwakman-Diamond syndrome patients, but for most of our patients seen at Dana-Farber, is an in-house sequencing test, DNA sequencing test, referred to as the rapid heme panel, which allows us to detect changes in the DNA or mutations in blood cells that can give us a sense of what's happening in the bone marrow and to gauge if there is a more or less risk of things changing in the years to come in the bone marrow. And relatedly, what we also strive to do is to set very explicit plans in place for blood surveillance, and I'll come back to that concept in some of the subsequent slides. And getting at this idea of a combined pediatric adult program, one of the things that we've been doing on a weekly basis now is meeting in the mornings on Fridays and talking about our mutual patients and getting the expertise of both the pediatric experts as well as the adult perspective. And so that's been very, very helpful in terms of deciding on appropriate next steps for patients and for appropriate pass-off as well for patients that are graduating from the pediatric side. And then the other thing that I think is really important to highlight is that Schwakman-Diamond syndrome is a multi-system, multi-organ disorder. And so it is cannot be approached in a single dimension. And so one of the things that we do for patients is to coordinate the subspecialty care as needed. And so many patients will have gastrointestinal issues that need to be managed by appropriate specialists. Additionally, there are many other subspecialty disciplines that may be brought on to the team if and when they're needed. So that would include rheumatology, endocrinology, neurology, and psychiatry. And then occasionally, sometimes patients do need evaluation by one of our transplant colleagues, stem cell transplant physicians, and we can arrange that quite rapidly at Dana-Farber. And then we also have a very close relationship with our genetics group as well, and any other that I couldn't list on the slide. So we try our best to and strive for a comprehensive evaluation in all of our consults and follow-up. So I'll mention a few general challenges that I think apply broadly to patients with Schwakman-Diamond syndrome across the age spectrum and across various clinical manifestations. And this is something that has been told to us repeatedly by patients and families as first, that because this is a rare condition, many people that they meet and encounter are understandably unfamiliar with the condition. They haven't heard of it, or they misconstrue it as something else, and so it takes time and takes patience as well to explain to individuals, both strangers and people that you know well, what Schwakman-Diamond syndrome is, what it entails, and why it requires such highly specialized care. And so that is something that I've certainly witnessed and have been informed of by patients, is that this idea that just not many people have heard about this disease, and so it can feel sometimes from their perspective that they're on an island and there's not enough resources out there. But this is what we're actively trying to help with the registry and with other outreaches like this as well. Related to this idea of it being a rare condition is on the provider level, so that we're talking about nurse practitioners and nurses and doctors and other people in the healthcare setting, also often have very limited knowledge and experience in caring for patients with Schwakman-Diamond syndrome. And that's totally understandable. It's a rare condition. And in medical school and in our training, we are taught all about various diseases and conditions that we may never, and often never, actually treat and see. And so Schwakman-Diamond syndrome, for many providers, is such a disease that they just maybe see it once in their career. And so you really run into this issue sometimes where patients feel like they know more about Schwakman-Diamond syndrome than many of the physicians they meet. And that can be also unsettling when you think about all of the care needs that these patients have. So you definitely want to feel like you're in good hands with someone that really has seen this and understands the management. And then lastly, one of the other general challenges that I've certainly talked to patients about is the concept and the fact that they must live with this underlying risk of complications, both hematologic and blood complications and others. And this idea that there's some uncertainty in terms of the ongoing care that they need. And that brings up both true medical issues, but also psychosocial issues in terms of how patients cope with these things. And so I think these three, while many more could be listed, I think they encapsulate many of the challenges that occur across the age spectrum. Now, when we think about the transition process from pediatric to adult care, there's actually some unique challenges that I can certainly list and identify that I think are worth talking about. And so the first is that many patients with Schwakman-Diamond syndrome are diagnosed within the first year of life. So very early on, they have been told that they have this condition, and they have been seen and treated by a group of care providers for years, if not decades, before they're finally ready to transition to adult care. And there's a lot of accumulated trust and faith in their team, and it can be disconcerting when you realize that this has to now be transferred and started anew with a new group of people. And so that is certainly something that I can empathize with, and has been told to me by patients and families, is that the idea of embracing a new care team is anxiety provoking, and understandably so. The other thing that goes along with a transition is actually the clinical environment is very different. And so I can relate. I remember being in my late teens and going to the pediatrician and looking around, and you're the oldest and most mature person in the room, and then you find yourself in the waiting room of an adult doctor, and you're surrounded by people that are decades older than you, have other medical problems. It's a very different environment. And so that itself can be something of a challenge and a fear, honestly, for some patients as they're kind of approaching this. Another feature that I think is worth talking about is, kids are diagnosed very early in life, but they continue to develop and grow. And they develop their own personalities. And eventually, when they're ready to come to an adult clinic, they're really starting to exercise their medical autonomy and independence in a way that they haven't before. And I think that's something that is both a really helpful thing for patients as they develop, but it can also lend itself to uncertainty and making sure that we engage the patient at the appropriate level as well, in terms of making sure that they can make as many decisions on their own as they feel comfortable doing. And one of those items that I'll highlight specifically is the idea of the bone surveillance and surveillance. And this is something that I'll spend a little more in the slides to come. Highlight this specifically and separately because This is something I feel obviously strong about as the hematologist, is that we know a lot more about what the risk is, and how blood complications can arise in patients with SDS. And so I feel very strongly that I really want to have a good plan for patients as they transition to adult care for their blood surveillance. Another thing that maybe has not been talked about much in your pediatric visits and growing up, certainly with young patients, but the idea that patients get older, and concepts of pregnancy for female patients, and ideas of family planning as well for all patients with SDS are things that do come up on the adult side. So it's its own unique set of issues that we have to navigate. And so while I think it's not a very common occurrence, certainly by any means, but we do have different specialties as well at our disposal to make sure that we address all of those issues as well regarding that. And then putting all this together, so what would I recommend for a patient, a family who is looking for an adult provider? And I think there's many things that could be looked for, but I think if I distill it to just a few, I think the most important thing, and I've learned this throughout my training as well, is you want to be adaptable and humble enough to recognize when you don't know an answer, and when you need to go back to the literature, when you need to go to a colleague and seek advice. And so the idea of being engaged first and foremost, and willing to learn, because anyone that has been in medicine long enough understands the idea that you never know it all. There are many things that come up that you haven't seen before, and I think it's important to have a provider and a care team that is willing to be adaptable and willing to continue to learn with you. Related to that is looking for adult team providers that have an experience not just in SDS, but the global care. And what do I mean by global care? What I mean by that is, it depends on how patients maybe come to medical attention, or their SDS comes to medical attention. So if for instance, a hematologist diagnoses them, they may be expert at managing all of the hematologic complications that go along with their SDS. But we cannot neglect the other manifestations and things that need monitoring. So making sure that we're keeping track of their nutrition, monitoring their pancreatic function, looking at their bone health, making sure that they have the neuropsychiatric support that they need. And so the global care, I think, is really important concept, and not strictly isolated to one specialty. And what can help with that is the collaboration and participation within the STS registry. And so I strongly encourage any providers for patients with SDS really understand what the SDS registry is, how they can get their patients enrolled, and what resources are available. So again, very, very excellent resource. And then also related to that, one of the benefits of being connected with the registry is you are always informed of the active areas of research and potential access to novel technologies and treatments. So it's really a great way to keep a finger on the pulse of what's happening in the SDS field. So some of the clinical management specifics of adult patients, I just wanted to we thought about routine, highlight hematologic issues primarily based on my field, and also the risks that is involved with patients with SDS. So this is both, blood monitoring, which is important, but not the only aspect of monitoring that these patients need. And so I'll mention a little bit more on the slides coming up. But the other things that we always emphasize are gastrointestinal related issues, specifically pancreatic function. And so many patients that are initially diagnosed will require some supplementation with enzymes to aid in their digestion and to help their nutritional status. Sometimes in many patients that actually lessens over time, and perhaps some have had some experience with their own children in that regard. But we also have many patients that remain dependent in some way and then some level on pancreatic enzymes. And so that need can vary over time. So making sure that that is constantly addressed. and relatedly, the other nutritional deficiencies that can result from those complications. And so making sure that they are maintaining a healthy weight, that they're having appropriate caloric intake, and specifically looking at certain vitamins, particularly fat-soluble vitamins that may be deficient in patients with poor pancreatic function. And then the other things that I would be, there's many other things that would warrant additional discussion and monitoring, but some of the things that come up routinely for us are osteopenia, osteoporosis. So bone health is really important, and it's quite surprising when you look at DEXA scans or imaging studies that look at the bone mineral density or strength of one's bones. Oftentimes they will be much decreased in patients with Schwakman-Diamond syndrome, and there are excellent therapies that we now have at our disposal to help improve that. And so the first step in that regard is making sure we understand the problem and diagnose it. So that's something that I do for all of my patients as well, is make sure we have routine monitoring of bone health. And then occasionally patients will also have some rheumatologic symptoms that are easily managed by some of our colleagues in rheumatology. And then, as mentioned, some of the cognitive and behavioral issues that may be diagnosed early in life may still be issues that require specific monitoring as adults as well. And so that's something that we're cognizant of. So I hope this slide encapsulates the concept of global care that I mentioned on the subsequent slide. So a few comments about blood complications. Let me see how I'm doing on time. Okay, we're good. Blood complications with SDS, so it's kind of a flavor, if you will, low count, and this can occur one or a combination of three things. So neutropenia, which is low neutrophil counts, and it can result in increased risk of infection depending on how low the counts are. And neutropenia in SDS patients can be chronic. Many times it is. Some patients need some growth factor support, Nugen or other related medications to help boost the bone marrow's production of healthy infection-fighting cells. Patients can also have low platelets. We call that term thrombocytopenia. And this can increase the risk of bruising and bleeding in patients, and that is another way in which this SDS deficiency can manifest in the bone marrow. And then also patients can have some anemia, and this can relate clinically to having low energy, poor ability to kind of exert themselves in sports and other activities, and so that's another thing that can certainly happen. One of the more feared complications of Schwakman-Diamond syndrome, however, is blood cancers, and this is something that is something I'm keenly aware of, and something I think about for all of my patients. And these primarily manifest as what we call myelodysplastic syndrome, also abbreviated as MDS, or acute myeloid leukemia, which is very much related in terms of how the disease process begins, but is a little bit more advanced in terms of its aggressiveness. So going back to the concept of neutropenia, neutrophils are the infection-fighting cells that we all have. They're the first responders, if you will, to when you get a cut or an infection somewhere in the body. These are the first cells to the site. And the risk of infection actually increases as the neutrophil count becomes less and less. And so we really become more concerned about this when patients are below an absolute neutrophil count of 500. And so that's something that the doctors who care for them should be monitoring closely and treating if needed with either antibiotics or occasionally some support with growth factors. And the really important thing to know about the neutropenia aspect of this, and this is true for many conditions, is that any fever really needs to be taken seriously. And by that I mean if there's any fever, greater than, our threshold is typically 100.5 Fahrenheit, and we ask them to call us, give us a call, let us know what's going on, and if need be, bringing them in immediately for evaluation to make sure there's not a serious infection at play. And so one of the things that we have all of our patients do is have an action plan. So if they do have neutropenia, if their counts are quite low, we have a plan in place. Okay, if I have a fever, if I'm traveling, this is what I'm going to do. I'm going to call, I'm going to go here, and we talk about having antibiotics on board, potentially prophylactically, and what we do around the time of any elective procedure as well. And so this is, I think, the take home is that having an action plan is quite helpful. And then in terms of the bone surveillance, just a word on this. Monitoring blood counts, as I mentioned, is really important for patients with SBS. So we typically monitor your blood counts, anywhere between 2 to 4 times a year, depending on the situation. But it's enough. And so really trying to quantify or gauge, rather, one's risk to develop blood complications. The blood counts don't tell part of the story. And so that's why we recommend routine surveillance of the bone marrow itself. And there's actually good data now out of the SDS registry that doing this approach actually improves outcomes for patients. They do better, actually, when they're undergoing routine surveillance. And this is, I think, really important when patients are at that precipice of transitioning from pediatric to adult care, because what we know now from the registry is that the feared complications from the bone marrow, MDS and AML, typically, is occurring in patients when they're approaching or entering adulthood. And so it's, I think, important to note that we really want to make sure we maintain the surveillance and don't let that falter at that time. Now, for adults, one comment I will make is that, we don't typically do a routinely IV, intravenous conscious sedation for bone marrows, but we absolutely have that capacity. And so we do typically local lidocaine for most of our bone marrow biopsies, but one of the frequent questions that gets asked as patients are transitioning from pediatric is what is that process like to have a bone marrow biopsy? And so what we've done now is made it very clear, and I'd like to highlight it again here, is that we are able to do IV conscious sedation. So a very, very similar approach that they've been through their entire lives or disease course up until that point. So I think that's a comfort to know that as well. And the assessment of the bone marrow is important. So not just the blood counts, but the marrow can tell us a lot of information. One is what is the concept of reserve is one of the things that I relate this to. So looking at the absolute number of cells in the bone marrow. Most patients with SDS will have lower amounts of cells than other people their age that don't have SDS. But we also want to see, are the cells that are there, are they developing in a normal way or an abnormal way? And one of the terms that you might hear referred to is dysplasia, and that's just referring to cells that are abnormal in the way that they look under the microscope. We also want to make sure that if there's any increased number of these immature cells called blasts, and if you have too many blasts, we worry about MDS and leukemia. And so that's another component of the assessment. And then we also look for any chromosome changes. And so those are additions or subtractions or other types of alterations of the DNA, and that we can detect by various methods. And that tells us another important piece of information. And then lastly, one of the things that we've been doing routinely now for several years is looking at the DNA sequences to see if there are blood mutations that can tell us something about one's risk of developing blood complications down the line. And this is something that I think has been very instrumental in the way we assess patients. So I just wanted to highlight one paper that was recently published, actually, just this year from this was a collaboration. So the study was first authored by Alyssa Kennedy, who's at Boston Children's Hospital, but many people that you may recognize from the registry were also involved. My mentor, Coleman Lindsley, and Dr. Shimamura were also on this study. And this was work that was done using samples that were banked on the SDS registry. So a real triumph in terms of what can be accomplished through this mechanism. And the take home here is what we can glean from the study is that when we sequence patients' blood and bone marrow with Schwakman diamond syndrome, what we found was that there are recurrent mutations in blood cells that define very clearly individuals that are at higher risk of developing leukemia, but often many years before they ever develop leukemia. And so one of the key drivers that was identified in this study is that mutations in a gene called TP53 are by far the most common mutations that eventually lead to leukemia in patients with SDS. Now, I wanted to highlight a few other components of this study. What this is allowing us to do is to identify patterns in the blood and bone marrow that portend a higher risk of complications later. Importantly, patients with P53 mutations do not uniformly develop blood complication, and that's really, really important to know. And so one of the things that we were also able to conclude from this study is that if we use some additional techniques, we can actually identify particular subtypes of these mutations that are really the most worrisome. And so this is something that is being worked on the research side to develop new strategies to use in the assessment of patients with Schwakman-Diamond syndrome to better gauge the risk of developing blood complications and leukemia. And so one of the things that we're also doing in that regard is using the SDS registry as a way to field questions from the community and questions from providers as it relates to some of these new molecular techniques to assess patients, because the more we look, the more we find, and the more questions that then arise about what is the best strategy? How do we go on from here, and well, what additional help might we need? And so one of the things that we're now doing is piloting a project where providers, physicians actually can submit a question to us about particular molecular findings in their patients, and we can give some general advice. And so what we can do is share knowledge about the registry and some of our own expertise and knowledge about the biology of Schwakman-Diamond syndrome and the blood complications associated with it. What we really cannot do is give specific medical advice about patients we haven't personally seen. I think that's important to highlight, but I think this is an ongoing effort that I think will bear fruit, and we're really excited about being able to extend this to the rest of the community. And so I'll just close by saying that treatment of SDS patients is very complex. Line requires dedicated medical team. Transition to adult care has challenges, and importantly, we're here to help in that process. And again, the SDS registry has been a tremendous resource for patients and families and providers, and we encourage everyone to make full use of it. So with that, I'll stop my screen share and happy to take any questions from the group. Okay.
That was a great talk. That was awesome.
That was a good talk. Even for us veteran families, it was nice to hear some of the things that we've heard so many times in a different sense, kind of, just because of your view on things. You would look at it a little bit differently than we would. We had a couple of questions come in via Messenger while you were talking, and I'm currently looking for them. Okay. At what age should patients transition to adult care?
That's a great question, and I think my answer to that is it probably depends. It probably depends on a few factors. I think most importantly, a patient's readiness to do so. I think it's really challenging to if patients are fearful to kind of push them at a time when they're maybe reluctant to do so. So I think understanding where the patient is in terms of their willingness to embrace that. So I don't think there's a specific cutoff that I could say uniformly would be the right time. I've had patients referred to me at 18. I've had patients referred in their mid-20s, some in their 30s when they haven't had a good place to go before that. And so it's certainly a spectrum of ages in which patients kind of make their way to us. I think one of the things that can help that process is when you have a program like ours where so for instance, if Dr. Shimamura has been treating a patient for years under her care, and they're now approaching their window to kind of come see us on the adult side, she can walk over. She can see the patient together, with me or anyone else, and it really lessens the level of things. It doesn't take it away, but it lessens the anxiety a little bit more about who are these people, and are they going to know my history, my background, the things that happened to me, and what, making sure that plan and that baton is passed without dropping it. And I think that's something that can happen at any time as patients are entering adulthood. So I hope that answers your question.
It does, for sure. I know that we've spent a long time, 8 years, building up our medical team to where we're comfortable, we're happy,
Yes.
we know everybody. When someone leaves our medical team, we're like, you didn't get permission to do that. I don't know what
I was just telling him that. I've told Dr. Bertouche I need years advance notice if she ever wants to retire.
We're going to do a lot of transition time here. Maybe it's some cognitive stuff. I don't really know.
With pediatric care, you're seeing them, right, from such an early age, but you're going through these major things with them, right? So they become like so they become so important, and then to pass that baton. One of the patients wrote that she was seeing a peds doctor into her 50s. So that tells you like that's
It's not
happening
uncommon.
too.
Yeah.
Yeah, not uncommon. Yeah. And
Absolutely.
often I'm seeing that they then transplant, right, in a pediatric center, right? So they may be in an adult center, but then transplant in a pediatric center that may be more versed in their transplant, right?
That's true, and I can also say our transplant group for patients that need it is exceptional. So at Dana-Farber, we have several hundred transplants every year, and we've had a few patients with Schwakman Diamond syndrome in the last couple of years that have undergone transplant and done really really well. And so we have that capacity too. But I absolutely agree. You want to have the expertise of a transplant center that has treated SDS patients, because the approach is unique, and you have to really understand that.
That's great to know. I didn't know that Dana-Farber was transplanting SDS adult SDS patients. That's great to hear.
So can outside doctors contact you for guidance of what they should be doing? Because as you know, there's not a lot of adult hematologists in the SDS world, which is why patients see their pediatricians for so long, even their pediatric hematologists, because they do know what it is. Is there an easy way? Obviously, we spoke a little bit before we went live about how it's not really feasible to transfer or to transport to Boston or Cincinnati, depending on where you are. For some families, it's easier. For some, it's not. And so that's what I love about our program, is bringing you to them, but we want to literally bring you to them. So what is the best way to do that without literally bringing you to them?
It's a good question. And I think, I feel like I sound like a broken record, but the registry is an amazing resource. And so how that can be helpful is that if patients are seen anywhere in the country, and their provider or themselves can be placed in contact with the registry, they do an excellent job of cataloging where people are, getting up-to-date contact information. And if there are questions by patients or providers, it's very easy to get in touch with us. So at the registry, all of our emails are listed. Our pictures, we have nice pictures, little blurbs about what we do and our focus, and our email addresses are just a click away. And so I think the pathway that is the best mechanism, I think, to get connected would be through the registry. And so I'm just immensely thankful that was set up, and I think it's
for international patients as well, Dr. Reilly.
So the international patients, that's an excellent question,
because we have people from Australia and Denmark, and we have people from other places here.
Well, certainly the SDS website is accessible to anyone, and so similarly our contact information, email addresses is visible and accessible to anyone across the world. But yeah, certainly the registry itself is the North American registry, but we're happy to help in any capacity for anyone around the world.
Sounds good. We had a patient write in, do you know Dr. Varit or Dr. Ravi in the Detroit area? They were my docs when I had my BMT at age 10, and now I'm 40. Are you familiar with them?
I know their names. I can't say I've had the pleasure of meeting them in person.
We have a successful transplant.
But that's wonderful news. Yes.
Yeah, a long time ago too. Same patient. I think he wanted... I think he's asking about the anesthesia, and a bunch of us were curious about that. I could personally say that my role before this role on the board was to talk to as many people on the sport page and whatnot. And when I got to the adults, when I would talk to the adults, a lot of them would say, I'm just so scared or done with doctors. And then the bone marrow biopsy came up a lot, especially the ones that didn't go under anesthesia, I guess. I don't know if they did a local at that time as kids, but they were scared because I think at some point in their life, like this is like the early 30s patients, they said like when they were children, they weren't put under anesthesia and they didn't want to go back to that. So can you mention that again? Because that does come up quite often.
No, and I'm glad you brought it up again. So I'll first say, for all patients, the kind of the standard approach to bone marrow biopsies is generally local lidocaine. So what it usually is unlike young children who really can't be squirming around and they really need to be still for the
Yeah.
procedure for their safety. Adults usually can follow directions, and so we use local lidocaine to make it as minimally uncomfortable as possible. But I have absolutely found it to be the case that it is helpful to have the option for IV conscious sedation. It's really helpful. And so not every place around the country can easily set that up. Have that, but that's something that I think is really, and you're really right that, this is a point and a concern for patients about they've under surveillance routinely every year with bone marrows or conscious sedation. All of a sudden, it's easy for years to go by, and they just don't seek the care that they need because of that.
They're so scared.
And that is a problem that's easily solved. Is that I think the take home is that we can always find a solution to that. And so having the option for IV sedation, I think, has been very, very helpful in making sure that we don't falter in the surveillance for patients.
Yeah.
Nicole, I want to jump before your next question and address Jess. She just said, my daughter's had the conscious sedation for her last 3 biopsies, and I don't like it. She comes out of it very badly. Personally, as a mom, we came up with Nathan's anesthesia cocktail years ago. We found what works for him. We write it down. I've brought it to Cincinnati. I've brought it to Boston. I've brought it to Grand Rapids. I've brought it to Ann Arbor. I say, this is what works. This is what we need. And like Dr. Reilly touched on, I loved it in the beginning of your talk. You said, I have to understand that I don't get to know everything yet. I'm still learning. And treating the parent as the 5th member of the team is always such a good idea, because I know what anesthesia works for my kid.
Right.
And so, Jess, I'll happily message you after. I'll message you our little cocktail that we do, because we found that Nathan woke up very hard to it too. And so we had to add different medications in.
Yeah.
He had to go to sleep, and then he had to take a nap. Like whatever the medicine in the middle was, so he had to take a nap. Like, whatever it was.
The next question's a good one. Is there any research being done on geriatric care of SDS patients?
That's a really good question. That's a great question.
We hit the good questions hard. We've got some really good viewers.
That's a really great question. I think not yet, but I really hope that there will be.
That gives me a lot of hope.
Yeah, that's actually a really great question.
Yeah. Just that we have adult SDS hematologists is phenomenal now. Michelle, do you see any others that came in?
Dina had one. It was, so for example, we have a group of patients at CHOP. How do we get them to buy into the adult care? Or because it's a children's hospital, do we have to go to another facility? Nicole and I were talking about this while you were talking. I said, because we're closer to Cincinnati, my family personally.
Okay.
Man, I wish Cincinnati had a Dana-Farber right next door. That'd be awesome. I know they just built the critical care tower, but we need an adult tower. Like, let's get it going, right? And then I was looking up that Cincinnati actually does have a cancer center. It's not attached, but it's there. And so I think, okay, so now I'll let you totally answer, but we were talking about this because I was already invested in creating one.
Yeah, I agree. I mean, I think it's difficult to replicate everywhere, but in big academic medical centers, I think it's possible in many of them. And it just takes coordination, and it takes, dedicated individuals on both sides to really make it happen. And so, it's worked really well in Boston because we're both physically right next to each other. And so the Boston Children's Hospital is right next to the Dana-Farber. And so and everyone is, trained together, work together. So there's just a rich collegial, environment there. But even in the absence of that, I mean, if you have good pediatric care, you have a cancer center with leukemia docs and access to transplant facilities. I mean, all the seeds are there to make a program like that. But it does take infrastructure building. But I think it's certainly possible.
Texas Children's Hospital they transferred to MD Anderson. It's right across the street. Yeah, which is nice to have it right there.
And as Lisa Jane wrote in and said, we struggle in Australia getting holistic care for SDS. I'll be getting my SDS partner, who's 33 years old, to the hematologist to check out the SDS registry for sure. He's just changed his hematologist. Thank you so much for the registry.
You're very welcome.
We have partners, right? It's always moms or patients on. It's nice to see partners on too, trying to help their loved ones. Yeah. This was great. Dr. Reilly, if we get any questions on the replay, can we send them to you? Yes.
Of course. Yeah, absolutely.
Yes,
Okay,
absolutely. I think this is such an underserved area of our community is because there's not, I think we've tried to figure out why there's so few adults that we have that get a hold of us. And it's, I think it's the age of social media is that the adults who are on social media now might not, I grew up growing up with social media. And so when I had a kid diagnosed, I said, my first friend sent me a neutropenia support group. And then from there, just you found your family. And so I don't know that the age that they were grown up in would have had something like this. And I think
it's a good point.
It's harder for the older ones that might not have had the connection or the camp, right? How long has camp been running? Not that, I mean, in the grand spectrum, not that long. They grew up with, and some of them didn't even get diagnosed until they maybe had, I know some of them had cystic fibrosis, right? Like the other cystic fibrosis. And then they were diagnosed later once the gene was discovered. So, or SDS-like or something, right? Like they didn't.
And we only knew about camp because of social media, because I remember I was sitting in Boston at the Ronald McDonald House. We had just left a meeting with Akiko, and she said, no, here's the gene right here. And I got a hold of you, and I said, oh, I'm registering for the neutropenia camp. Nicole said, why are you going there? What are you doing? You've just been diagnosed. You need to come here. Like, what are you doing? And so I wouldn't have found out about it. Our doctors don't know a lot. We follow Dr. Myers in the registry for things, and it's very, very helpful. Jackie says, thank you from the adult patient community. Maria said, my son is 4 months old and I got diagnosed in October. What can I look forward to happening for him?
It's a good question. A difficult one to answer, certainly. But I think the best person to answer that, I think, would be whoever's caring for them on the week to week basis. But I think what I would say is that the surveillance and the global assessment, I think, is really what's most important, and recognizing that it's treating the patient and not only the disease itself. So not allowing or trying to avoid, I should say, letting patients think that something's wrong with them, right? That they did anything to deserve this, or that they're so different from their peers and things like that. I think that's really hard for kids to have that perspective. And so recognizing that they're just like everybody else, they just need to go to the doctor a little bit more often. But they're going to have a great life.
Today, Dr. Reilly. Thank you for reminding me that.
I have a sub-question to the answer of that first question. You said surveillance. What does SDS surveillance look like for an adult patient?
Yeah,
I know what it looks like for a pediatric patient because we do that. We made the routine, but.
So I will say, so what we do on the hematology side is for patients that have stable blood counts, nothing active going on in terms of any areas of concern. They're not on growth factors. We typically see patients probably every 4 months, every 3 to 4 months. And from the leukemia surveillance perspective, again, if there's no, if at a baseline, we would probably do a bone marrow most of the time every year. Usually, if there are concerning findings that we want to watch more carefully, we might decrease the interval, at least for a time, just to make sure we have a close eye. It comes up sometimes where patients may not want to do a bone marrow biopsy that frequently. And that comes up. And I think it's a partnership. It's a partnership and meeting the patient where they are and having a very open discussion about here's what we can know from the blood, here's what we can't know. And making sure that we agree on a plan that everyone feels comfortable with.
Dr. Reilly, are you finding it's a struggle to get the bone marrows covered under insurance for the adults?
That was something we had brought into us. I forgot. Good job, Nicole.
That's a great question, and that may vary from for a lot of reasons, but it has not been a huge problem for us.
Okay.
And if it requires some additional documentation or communication with the insurance company, and now with these papers coming out from the registry and the new study that I mentioned about the molecular monitoring, I think it's a strong argument to insurance companies that there's a good rationale to do this, and so
I'm glad you guys fight for that if it's not covered.
Yeah, and if they're not aware of the resources and the data, then we can provide that, and that's the rationale.
Great. Can you define global care for those
Yeah.
I think some people may get confused by that term. Like I've heard that term, but I think some of our viewers might get a little confused.
That's a good point. So,
Yeah.
you know, what I'm referring to is that SDS is a systemic disorder, meaning that
Right.
every cell in the body
Mm-hmm.
has the same SPDS deficiency. If we're focusing on just the majority of patients that have the SPDS mutations,
Right.
but recognizing that regardless of the gene involved, it is affecting all cells.
Right.
And so complications can arise. We think about predominantly the pancreatic issues and the blood issues as the cardinal features, but any organ system can be affected.
Mm-hmm.
And so recognizing that we're not, we cannot pick and choose the organ system that we want to focus and ignore the rest. And so the global concept that I'm speaking to is understanding the individual as a patient first and foremost, but also understanding the disease and all of its potential manifestations.
So are your patients seeing like a hepatologist, right? The liver can become an issue later, more of an issue later, right? It tends to get a little better at school age, but then can get a little worse or a lot worse in adult. Is that what are the doctors that your patients are like? What are the list, right? Because as children, they have a long, like my son is taken out of school sometimes 2 to 3 times a week. I'm not kidding, for to see different doctors, right? By the time they become an adult, what would you say, like a list for them to, because they're having to leave work, they might have families of their own, they got a lot of stuff to juggle.
I see myself as the analogy is like a sports analogy would be like a quarterback or a captain of the team or something.
Right.
Like that.
That's exactly what you guys are. I feel it's a little unfair. I've said this to Akiko and I've said this to Dr. Bertucci before. Like, you guys are the ringleaders for all the other, right? You guys are like, no, we got to get you in with hepatology. We got to get you in with GI. Like, you guys are I'm happy that you at least take on that. Like, you guys take on that role. Yeah. Like, no, that's just part of the gig, right? With SDS. Yeah.
It's part of it. It's what's needed. It's what's needed for the patients. And, you know, recognizing that you have like our expertise is the blood, but then recognizing that it's the care coordination part of it that is actually essential. And so making sure, and this comes up with you know, other conditions as well, where, you know, it can involve many organ systems, and making sure you have close partnerships, clinical partnerships with other subspecialty providers that have a vested interest in caring for patients with these rare disorders. And so to answer your question, you know, what we certainly do, in addition to monitoring the blood counts, is we monitor organ function in general with labs every time we see patients. And so if there's anything that is concerning or warrants additional investigation, there's a low threshold to say, please go see, you know, this person specialist in this field. But I also recognize, particularly for adult patients, they have lives, they have jobs, things like that. So it can be really challenging to maintain that and see many
on a regular basis. Yeah,
it can be tough. So I try to be selective, but I also try to be comprehensive in terms of, you know, what they actually need.
It's a whole new challenge, right?
Yeah,
you get to an adulthood. Okay, I think that's it, right? Michelle, do you see anything else coming in? Okay,
no, I think we got them all. I think, as always, if everyone has any other questions that you didn't get a chance to ask, or just message them to us, email them to us, we can get them to Dr. Reilly and then get your answers for you.
And again, big shout out that Dr. Reilly is coming in from Atlanta at the American Society of Hematology conference. He's not up in Boston right now. He's doing one extra thing for us. Thank you so much. Thank you to Greg running behind the scenes tech for us. Was this better than Ash?
This was great. Yeah, no, it's not.
We have had technical difficulties on the show before, but he said Ash has been a little bit of a challenge. So thank you so much. We have one more that just came in. Hold on. I arrived a bit late, so I apologize if this has already been addressed, but my son will be 18 in 6 months, and he's just now in the heart of puberty, and he has his normal lab values. Should we expect these levels to stay the same or change as he becomes an adult? Great question.
That's a great question.
Good question, Julie. Way to come
in hot, Julie. Coming in hot at the end.
So if I understand correctly, the blood counts are improving.
Normal for him, right? Normal SDS, right? That's what it sounds like, right?
Gotcha.
It has normal baseline
dramatically. Yeah.
I see. So no, it's a phenomenon that we definitely see, and so there's definitely effects of, you know, varying hormone levels on the blood counts. It's absolutely something that happens. Whether or not that is a consistent trend for the years to come, it's really difficult to predict. And certainly, we've seen that low blood counts in patients can be very intermittent. And so
Right.
it'll be helpful to see a trajectory, right? So multiple, time points over the next several years to kind of get a better sense of how things are trending. So it's always difficult to predict. But
I know the registry had just put out something saying that blood counts can get a little better as the patient gets older, right? Yeah.
absolutely.
As they age, right? Can get a little, like compared to as an infant or early childhood, the blood counts can get a little, may not go be amazing or even normal values, but they can get better. Yeah. That's a trend that you guys see. Yeah.
Yeah,
I
absolutely.
didn't know that. Actually, that was something I learned from. I could see it anecdotally, like through the community, but that was cool to hear from the registry that that's something that's been studied. Okay, thank you
I think we
so
want to
much.
thank everyone for joining us this evening.
Yes,
I'm
thank
sorry
you.
we went a little bit over on
Yeah.
time. It was such a jam-packed informational presentation, and I think it was helpful for veteran families, new families, all the families. If you have not already done so, please join the
Join the
SDS registry. This information is critical to us. So much research is done because of the registry, because alone we're rare, but together we're strong, right? And so if we've got all of us together on one registry, then it's so much work can be done. Please join the registry. We put the website in the comments above if you go ahead and scroll up, or it's just www.sdsregistry.org.
Yeah.
I highlighted in the comments that you can actually even request your Marrow kits, your yearly Marrow kits, on the website now. You don't have to call anyone, you don't have to email, just call, or just go on the website. But thank you everyone for joining us tonight. Thank you, Dr. Reilly, for joining us from Atlanta. Super appreciative. Everyone be safe. Wash your hands. Stay well.
We're just gonna
wash your hands again. Keep washing your hands. Just wash them all the time.
Yep.
Have a good night.
Have a great Christmas. Thank you,
Have
everybody.
have a good Christmas. Happy holidays.
Happy holidays. Bye. Bye. Bye.
Happy
Thank you,
holidays.
Dr. Reilly. Bye. Bye.
You're welcome. Bye.
That was a good one. Can you hear my kids with the musical instruments in the background?
I sure can, but we're still live.
Oh.
But I'm excited for these musical instruments. This is like an after.